This website makes learning so easy. I found all my resources here.
Like what you shares.
Desmology analyzes the body's dynamic ligamentous systems, transitioning from musculoskeletal support to complex peritoneal folds, and even tracing the fibrous remnants of our fetal circulation.
Joints comprise the active articular apparatus. Muscles and tendons, ligaments serve as dense, fibrous, connecting bone to bone. This analysis clarifies musculoskeletal pathology. True articular ligaments consist of dense, regular connective tissue. Parallel-aligned type I collagen fibers form the majority of its dry weight. Spindle-shaped fibroblasts maintain this extracellular matrix.
Ligaments are viscoelastic. Under constant load, they exhibit creep and stress relaxation over time.
In the toe region, crimped fibers flatten and return. Past the yield point, micro tears cause permanent elongation. In the toe region, fibers flatten and return. Past the yield point, micro-tearing and permanent elongation occur. The outer epiligament is highly vascularized. It acts as a primary source for wound healing. In Ayurvedic anatomy, ligaments are referred to as snayu, with 600 in the extremities, 230 in the trunk, and 70 above the clavicle. Pratanavatthi are the branched ligaments of the joints. Vritta correspond to circular cords or dense tendons. Sushira are hollow structures at visceral exits. And pruthu are broad flat sheets in the chest and back.
Injury to the snayu is associated with vata. This explains why ligament trauma generates severe pain. These structures are vital targets for preservation.
The human body contains approximately 900 distinct ligaments. They facilitate upright posture and complex movement. This is its comprehensive map.
In the head and neck, the cricothyroid ligament connects the cricoid and thyroid cartilages. It maintains an open airway. This is the site for emergency cricothyroidotomy during upper obstruction.
Located in the head and neck, the periodontal ligament is vital. It attaches tooth cementum to the alveolar bone socket. This suspends the tooth and absorbs occlusal forces. Within the eye, the suspensory ligament anchors the lens. It connects the ciliary body capsule. During accommodation, ciliary muscle contracts. This relaxes the ligament to adjust lens curvature.
The phrenoepiphyseal ligament connects the diaphragm to the esophagus. It permits sliding during respiration and swallowing. With age, this ligament can attenuate, leading to reflux and hiatal hernias.
The anterior sacroiliac ligament connects the sacrum to the iliac fossa. This broad band resists separation and shear forces. This can lead to pelvic instability.
The posterior sacroiliac ligament. It connects the sacral tubercles to the iliac spine. This strong band resists pelvic ring displacement. It is the primary stabilizer for vertical shear loads. Sacrotuberous ligament. It attaches from the sacrum, coccyx, and ilium tuberosity. It resists upward tilting of formed sciatic boundaries. Pathology includes pudendal nerve and causing chronic pain.
The sacrospinous ligament. It connects the lateral sacrum to the ischial spine. This converts the sciatic notches into foramina. It acts as an anchor in fixation surgeries.
The inferior pubic ligament spans the pubic arch. It is subject to severe shear stresses during running. In the inguinal region, we find the reflex inguinal ligament, formed by contralateral fascial fibers crossing the midline. It reinforces the posterior wall of the canal. The superior pubic ligament is located here. It attaches across the superior pubic crests. It functions to stabilize the anterior pelvic ring. In athletes, chronic microtrauma leads to osteitis pubis.
The human pelvis is a complex bony structure. It supports the torso and connects the lower limbs. This region contains vital vasculars. Understanding this anatomy is key for clinical practice.
The pubic symphysis is a non-synovial joint. It connects the left and right pubic bones. It is strengthened by the surrounding ligaments. These maintain pelvic stability. The palmar radiocarpal ligament. From radius to capitate, it limits wrist hyperextension and is often injured in falls. on an outstretched hand. The dorsal radiocarpal ligament is a key stabilizer. It attaches from the distal radius to the proximal carpal row. It limits hyperflexion and maintains alignment. Preserving it is crucial during surgical exposures. The wrist. This is the ulnar collateral ligament. It connects the ulnar styloid process to the triquetrum and pisiform. It resists excessive radial deviation. Repetitive throwing can cause injury. Today we explore the wrist's anatomy. It connects the radial styloid to the scaphoid. This ligament resists excessive ulnar deviation. It is often injured with scaphoid fractures. This makes it critical in wrist sprains. The wrist is a complex joint. The scapholunate ligament connects the scaphoid and lunate bones. It is critical for stability and load transmission. Disruption leads to dissociation. This causes carpal collapse. The anterior cruciate ligament, or ACL. It connects the anterior tibial plateau to the lateral femoral condyle. Frequently ruptured in sports, it requires reconstruction. The LCL connects the femur to the fibular head. It functions to resist varus stresses. High-energy medial blows can cause severe tears. This stabilizes the posterolateral corner. The PCL connects the tibia to the medial femoral condyle. It restrains posterior tibial translation. Direct blows create dashboard injuries. The knee's medial collateral ligament, or MCL, primarily functions to resist valve. While a common sports injury, it possesses high intrinsic healing potential, the canine knee joint. It is equivalent to the human ACL. It restrains tibial translation. This ligament degenerates over time, leading to cranial drawer instability.
The stifle joint, or the knee. This is the caudal cruciate ligament. It is the quadruped equivalent of the PCL. It restrains caudal tibial translation. Injured in severe trauma, it leads to luxation.
Today we analyze the knee's posterior region. The oblique popliteal ligament spans from the semimembranosus tendon. It tenses to restrict hyperextension. Pathology involves posterolateral instability. The patellar ligament is a key structure. It attaches the patella to the tibial tuberosity. It transmits force from the quadriceps. Explosive jumping can cause tendinopathy or rupture. The scapholunate ligament is a key wrist stabilizer. It's divided into three distinct portions: translational stability, disruption movement, culminating in degenerative arthritis. Fibers arise from the contralateral aponeurosis, passing through the superficial inguinal ring. They cross the midline to insert onto the pubic crest. This reinforces the wall, resisting herniation. In humans, we focus on the ACL and PCL. Quadrupeds have a cranial and caudal cruciate instead. Different standing postures create unique mechanical stress. Unlike the human knee in full extension, the quadruped stifle sits in constant flexion. Its steep plateau angle creates a continuous cranial tibial thrust and a persistent shear force. In humans, the ACL prevents anterior translation, while the PCL limits posterior translation. In quadrupeds, the CarCL prevents cranial translation, and the KCL limits caudal translation. The human knee operates in an extended column, loading the ACL during dynamic movements, but the canine joint remains flexed. This exposes the CRCL to continuous loads. In humans, the tibial plateau is nearly flat, but in dogs, this angle ranges from 20 to 30 degrees. This slope creates a forward force, cranial tibial thrust. The force magnitude is Fg times the tangent of theta. Unlike acute human ACL tears, quadrupedal injuries are typically chronic. Continuous stress causes microtearing, leading to progressive degeneration, effusion, and osteoarthritis.
Peritoneal ligaments are specialized double folds. They support organs and serve as neurovascular conduits. They consist of a mesothelial monolayer,
The phrenoesophageal ligament connects the esophagus to the diaphragm. It divides into two limbs at the hiatal margin. The lower limb inserts into the cardia and fundus. This ligament acts as a flexible protective sleeve. It permits independent movement during breathing, coons of mercury. Chronic strain or weakening, associated with hiatal hernias and GERD, degeneration and pressure spikes degrade collagen fibers. This loss of elasticity allows the sphincter to migrate. It moves cranially, disrupting the mechanism. This predisposes to acid reflux.
The hepatoduodenal ligament forms the thickened right free margin of the lesser omentum. It extends from the duodenum to the porta hepatis, enclosing the portal triad.
Clamping the hepatoduodenal ligament, known as the Pringle maneuver, compresses the hepatic artery and the hepatic portal vein. This arrests blood supply to limit hemorrhage.
The broad ligament is a double-folded sheet. It extends to the pelvic walls and floor. It drapes and partitions the pelvic cavity, supporting the internal organs. The broad ligament is divided into three distinct functional subregions: the mesometrium, the mesosalpinx, and the mesovarium. Between the layers lie the ovarian and round ligaments. Defects can lead to internal herniations. Small intestine loops may slip through the defect, causing obstruction or strangulation.
Before birth, vital conduits sustain the fetus. At birth, flow shifts, triggering closure. Pathways remodel into fibrous cords. These are fetal remnant ligaments.
Ductus arteriosus, elevated 2 and dropped PGE2, smooth muscle contraction and dense fibrosis. Ligamentum arteriosum, closure failure leads to heart failure.
In the fetus, the left umbilical vein carries oxygenated blood. Cord clamping triggers a sudden pressure drop. Thick collagen bundles then obliterate the lumen. It remains as the ligamentum teres.
At birth, umbilical flow ceases. The ductus venosus constricts. It turns into a fibrous band. Failure to close leads to a dangerous shunt.
At birth, the distal umbilical arteries carry blood from fetus to placenta. Cord severance triggers autonomic spasm and a sharp pressure drop. Proximal umbilical arteries alerts to in utero, the ductus arteriosus shunts blood. It redirects 90% of right ventricular output. At birth, rising oxygen causes it to close. It leaves behind the fibrous omentum arteriosum. At birth, lung expansion decreases pulmonary resistance. This rise, plus the loss of functional closure of the ductus arteriosus within 24 to 72 hours. Depolarization of smooth muscle cells is due to the inhibition of potassium channels. Influx of calcium triggers contraction of smooth muscle fibers. Constriction shuts down luminal blood flow. Hypoxia triggers growth factors. Migrating smooth muscle cells form intimal cushions. Deposition of dense collagen completes obliteration.
Clamping the umbilical cord triggers vascular remodeling. Loss of placental flow causes a rapid fall in pressure. The extrahepatic vein undergoes complete fibrosis.
This process forms the ligamentum teres, but hypertension can force it open. This leads to recanalization. Varices develop on the abdominal wall. This is known as caput medusae. In the fetus, the ductus venosus acts as a vascular shunt. Postnatally, this shunt undergoes functional closure to the fibrous ligament venosum, separating the caudate and left lobes. The distal portions also transform. These arteries contract in response to autonomic signals and the rise in oxygen tension following birth. They form the medial umbilical ligaments. In contrast, the proximal segments remain patent, continuing to function as superior vesical arteries. These vessels supply the bladder and ureters, and in males, the ductus deferens and seminal vesicles. Medial umbilical ligaments must be distinguished from the lateral umbilical folds housing the inferior epigastric vessels and the single median umbilical ligament.
Ligaments have a limited capacity for natural regeneration. Disorganized type 3 collagen creates weak scar tissue. We are engineering novel synthetic biomaterials. These scaffolds guide progenitor cells to regenerate tissue.
Activated by strain, these stem cells rebuild damaged tissue. They differentiate to reconstruct the bone and ligament complex, a breakthrough for regenerative medicine. For ACL reconstruction, synthetic scaffolds are used. Common polymers include PET is hydrophobic, lacking biological signals. This can lead to graft failure in the bone tunnel. To promote ligamentization, fibroblasts colonize the scaffold. Polynas grafting improves adhesion, while silk fibroin coating exposes amino acids. These modifications decrease the water contact angle. Fibroblasts exhibit unregulation of collagen gene expression. This initiates the deposition of an extracellular matrix. Ligaments are dynamic tissues. Comparative analysis highlights biomechanical loads. Regenerative medicine addresses vascularity. This guides surgical techniques and rehab.
Like what you shared.
This website makes learning so easy. I found all my resources here.